Hi everyone, I'm Dhanyata and I go to King Edward's Camp Hill School for Girls in England. It's an honour to be presenting here about global chronic pain management. Let me share a bit about myself with you now. In my free time, I love doing karate, singing and playing the piano, as they really help me relax during times of stress. And within the field of academia, I'm doing an extended project qualification about the genetic influences of pain perception. I also lead debates about current medical issues for a 1,600 member book club. And to narrow down my interest in the healthcare sector, I volunteered at my local pharmacy, vaccination clinic, and I'm now going to volunteer at an orthopedic hospital. So here's an overview of what I'll be presenting about today. First, I'll go over a brief history of pain medication and a bit about opioids in particular. Then I'll present to you the recommended pain management, cultural and gender influences to pain, and link it to today's situation by talking about long COVID and the economic implications of pain management. I'll finally conclude with suggestions on how to better manage the situation in the future and consider how these could be conflicted with the ideologies of global health. So I've chosen the topic of global pain management because pain is one of the most common symptoms and accounts for 20% of the total days with serious health-related suffering worldwide. Yet, pain relief medicines are severely lacking. An estimated 3.6 billion people, 50% of the global population that reside in the poorest countries, receive less than 1% of the distributed opioids measured in morphine equivalent. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The same organization stated that chronic pain currently affects 1 in 5 adults, is more prevalent among women and the elderly, and is more associated with physically demanding work and lower education. The purpose of pain is to notify the body's defense mechanism to react towards the stimulus in order to avoid further tissue damage. Chronic pain can be inflammatory, such as that associated with osteoarthritis, or neuropathic, which includes pain caused by direct injury to nerves. It leads to diminished quality of life, physical disability, and is a serious risk factor for suicide, rendering pain management an essential component of medical care, according to Pala. The Centers for Disease Control and Prevention stated that 841,000 people died from a drug overdose from 1999 to 2009, and over 70% of those overdose deaths involved an opioid-like prescription. It was in the 1980s when pain became increasingly recognized as a problem that required adequate treatment. This was because pain was acknowledged to have adverse effects on function and social and psychological well-being, even though it usually serves as an adaptive role. Acts were passed allowing physicians to treat their patients' pain aggressively with controlled substances without fear of prosecution. In the mid-1990s, the introduction of new opioid-based products contributed to a surge in their prescriptions. The use of opioids to treat chronic pain became widespread, even though they are particularly effective in treating it. With long-term use, users can become tolerant and become even more sensitive to pain. More people in the United States died from overdoses involving opioids in 2017 than from HIV or AIDS-related illnesses at the peak of the AIDS epidemic. In the same year, the US Department of Health and Human Sciences declared a public health emergency and announced a 5-point strategy to combat the opioid crisis. The opioid epidemic might not be able to be contained in the US. Other countries could be vulnerable to its spread, especially as it's easier to prescribe painkillers to those with idiopathic conditions during the pandemic in a free healthcare system like India's National Health Service. Global surgery is a rapidly developing multidisciplinary field. It aims to provide improved and equitable surgical care across international health systems. Some prerequisites aren't evenly distributed globally. For example, the availability of trained anaesthetists, proper equipment, and the drugs for drug administration, facilities for safe blood transfusion services, and the setup to manage expected emergencies. The economic impact of pain is greater than most other health conditions due to its effects on rates of absenteeism, reduced levels of productivity, and increased risk of leaving the labour market. It has been estimated that 1 million working days were lost annually in Denmark as a result of chronic pain. Dr. Kernelson, writer of the series on the history of pain and the practical pain management, argued that the best treatment of chronic pain involves a multidisciplinary approach and referring patients for psychological treatments before their medical treatment fails, so the patient won't interpret the scenario to mean that the pain must be all in their head. In this article, he explored the different types of pain treatments already available, which I'll now briefly go over. So the World Health Organization first published the Pain Ladder in 1986, which describes pain in terms of intensity to direct pharmaceutical pain treatments. Non-opioid analgesics, including non-steroidal or anti-inflammatory drugs and aspirin, are recommended at step 1. If the pain persists or worsens, the physician should prescribe analgesics and weak opioids from step 2. Step 3 is reserved for patients with moderate to severe pain and calls for the use of strong opioids. It can be helpful for the physician to know their patient's psychological profile before entering into a long-term relationship of opioid prescribing. However, it may not be feasible in rural areas where pain psychologists are scarce. Non-pharmaceutical approaches include invasive treatments such as back injections and amputations, acupuncture and trigger point injections, implantable pain technology such as spinal cord stimulation, non-invasive treatments such as transcutaneous electrical nerve stimulation, and behavioral treatments such as relaxation therapy and CBT. There are many cultural influences to pain. Here are some examples. So Carey and Garrett found that in a comparison to white patients, black patients recorded worse disability as measured by the Roland-Morris Disability Questionnaire and higher pain scores on a 10-point scale in comparison to white patients. Yet, clinicians considered black patients less likely to have disc disease and to have less pain than white patients. Also, when women are in pain, they wait longer in emergency departments and are less likely to be given effective painkillers than men. Here's one patient's experience. In 2009, my doctor told me that, like a lot of women, I was paying too much attention to my body, saying there wasn't an issue. He suggested I just relax and try to ignore the symptoms. There's a growing evidence that COVID-19 infection is associated with myalgias, referred pain, and widespread hyperalgesia, and also the general pre-existing problems that have been exacerbated as a result of the COVID-19 pandemic include opioid overuse. So how can we manage the situation? First of all, marginalized groups should be advocated for, especially those of ethnic minorities, and women to be treated equitably. Our understanding of pain is crucial in finding ways of quantifying it so that these groups are not ignored. If healthcare professionals empathize with their patients better, patients are more likely to return to the hospital for their doctor's expertise and in turn be more responsible for their own health. So most of the options for treating pain that have arrived in the last 30 years have been borrowed from epilepsy or neurology. A medical neuroscientist called Jiango Cheng at Cleveland Clinic in Ohio said, "They're often only partially effective or come with intolerable side effects. The adjuvant treatment includes anti-epileptics like gabapentin. Non-allopathic medicines include Ayurvedic, acupuncture, yoga, and homeopathy. And the subjective nature of pain research has caused pharmaceutical companies to shy away from pain research. However, the opioid crisis is fueling pain research initiatives such as HEAL, which is helping to end addiction long-term by the US National Institutes of Health, which is injecting $850 million into the project. Fresh avenues of research include monoclonal antibodies, toxins, channel blockers, for which in 2002 researchers heard about a boy from Pakistan who was impervious to pain and they studied him. He was presumed to have a mutation in the NAV 1.7 voltage gated sodium channel protein that controls the entry of sodium ions into neurons. And this channel is crucial for pain amplifications in neurons because a study of families from Pakistan who did not have experienced any pain showed that the family members have a mutation in that same gene. However, it's extremely difficult to track the activity of one type of ion channel, and it might not be enough by itself. Also, the use of stem cells could also help. Finally, pain and the ideologies of global health. Within the biomedical model, treatment and eradication of disease is prioritized. Pain is often seen as a mark of failure. Focusing on pain doesn't necessarily prevent care, but it often means that resources are directed at treating disease rather than addressing the suffering that it produces. For example, the Bill and Melinda Gates Foundation's grand challenges in global health include vaccine development and improvement, vector control and improved nutrition, treatment of latent and chronic infections, and improved health measurement in developing countries. But they make no mention of pain. The 2010 Global Health Program overview contains no reference to pain or pain management. And some final words from me. We need to use non-opioid analgesics as previously discussed, pharmaceutical, non-pharmaceutical, and psychological techniques, and utilize these resources to target better training and education, for example, at a community level, further research, and target the availability or lack of resources and their utilization to improve global health and to overcome disparities. I'd like to thank my family for being so supportive, and not to mention the hosts and everyone here for giving up your time to listen. You can contact me via my email and slides if you have any questions. And here are my references.